The ocular surface means it is the conjunctiva and the cornea, and also the lid adnexa. Lid adnexa, I mean the lacrimal glands and the accessory lacrimal glands which are there in the cornices. So the lid margin is also important as a part of an ocular surface. Because the lid margin is it's actually divided into anterior and posterior margin by a gray zone. So this anterior margin is purely has cilia, 2 rows or 3 rows of cilia, and the posterior margin has the openings from the tarsal glands, that is known as meibomian orifices. So these meibomian orifices give they supply lipid layer to the tear film. They form the lipid layer of the tear film. So this outer layer is the lipid layer of the tears. This everyone knows. And the middle layer would be the aqueous layer. So the aqueous layer is secreted from the lacrimal glands. So which are and the accessory lacrimal glands of Cors and Wolfram. And the innermost layer would be the mucin layer. The mucin layer is secreted from the conjunctival goblet cells. All these 3 layers actually it protects the corneal surface and the conjunctiva by evenly spreading over to the ocular surface and also nourishes the cornea. So this tear film is very important. So if there is any problem that occurs in the tear film, you get ocular surface instability. So this, since the oil layer is from the lids, if any problem that occurs in the lid would affect the tear film and impact the ocular surface. So this leads to ocular surface disorders. So how to examine an ocular surface? So whenever you are seeing in the slit lamp, just examine first the blink. So how the patient is blinking, whether it is a complete blink or an incomplete blink. So because of even this incomplete blink will lead to an evaporative dryness in these patients. And also the lid position, how is the margin of the lids and how the lashes are present, whether it is inward or outward, and how about the inferior fornix. Pull out the inferior lid down and look into the inferior fornix. Same way, invert the upper lid and look into it. So this should be the line of examination. So first the lid position, lid margin, the blink reflex, and then the lashes, everything, and then the inferior fornix, and then the superior fornix. I just invert the superior tarsus and see, look into the any foreign bodies, whatever it is there. So, and then the conjunctiva and the limbus and the cornea. So, any congestion in the conjunctiva or whether it is constrained to the limbus or in the cornea, so whatever it is. So, also examine the tear film. So, this actually is a patient who has come to us with a mask. Okay. So, like very recently. So, nowadays we no patient wears mask. Even in COVID time, patients don't wear masks. So, this patient especially was wearing the mask and we were doubtful why this patient is wearing. When we removed, we could identify there is some asymmetry in the face. So all these things will mislead us. So ask the patient to close the eyes. So even though this patient has a very good Bell's phenomena, this patient had this exposure keratopathy. Why? That is because of the incomplete blink that occurs in this patient. So whenever the patient blinks, there is a complete closure in this eye, but there is no closure in this. The movement is restricted and there is exposure and patient is getting keratopathy. These patients should be referred immediately whenever you identify this patient because they need emergency torsography to avoid all these complications. So the most common ocular surface disorders are lid swellings, which we see in the clinical practice. Like there are so many varieties of lid swellings we see. So all lid swellings, we have to give oral antibiotics and anti-inflammatory, but ask the patient for drug allergy. That is more important because there is, I don't know, recent times there is sudden rise in Stevens-Johnson syndrome. It is a condition of drug allergic reaction which affects the mucocutaneous membranes. So wherever there is a mucocutaneous membrane, there is an allergic reaction which is fatal in many circumstances. So this, like conjunctiva, is it has a mucocutaneous, it's a mucocutaneous membrane. So it easily affects and it causes a chronic ocular surface disorder. And blepharitis, it's a very common thing which we can treat in the vision centers. So these eyelashes, but it is difficult to treat. You have to make the patient understand that the irritation, whatever the congestion or the foreign body sensation is due to these lashes. You can take a photograph, clinical picture if possible, even from your cell phones. I usually tell my patients, take a photo and show them how their lashes are. So they understand better, much better, and they realize the thing, and then they would be compliant with our treatment. Then this is the normal ocular surface. See how the tear film. So this is around 0.6 mm thick, and it is the surface is smooth. And look at this tear film; it is thinner, and this is a patient with a post-IO surgery. See the lid margins. This is due to poor lid hygiene. Usually, I'll ask the patient, sisters to wipe around the lid margins, clean that, and then show to the patient. So, how is the hygiene? Just make them realize how's the hygiene of them. So they realize, and then they get treated. And this is a case of a squamous cell, squamous blepharitis. There are plaques and a scaly material in the eyelashes, which can be easily removed, but easily treatable also. This is usually these seborrheic blepharitis are associated with MGD. So this MGD also can be easily treated in the vision centers, but carefully expressing the gland orifices like this. We can use a buds onto either side of the lids and carefully express all the secretions. The patient will be relieved of pain. So this is again another condition caused by a mite. So what to do for patients with a blepharitis? So just give lid hygiene, advise lid hygiene. If there is a poor lid hygiene, and you ask them if you use wipes or cotton dipped in warm water, clean it frequently. Use chloromycetin, hydrocortisone, eye ointment if there is no keratitis. Give tear supplements. That is very important because these patients are lipodeficient, so they are more prone for an evaporative dry eyes. So hot fermentation is very important because the meibomian glands get expressed out automatically because of hot fermentation, and swelling subsides. So refer if cornea is involved in cases of recurrent blepharitis or recurrent conjunctivitis. So lid swelling, I told you, if there is a negative history for drug allergy, please you can prescribe oral antibiotics and anti-inflammatories. And all lid swellings, if it is not resolved more than 3 weeks, please refer to face hospital. So dry eyes, don't get confused with this slide. Like dry eye, if you take, it is divided into an organic or a functional dry eyes. So functional, I mean, like because of some low blink rate, as I told you before, I showed you in that patient, the low blink rate or incomplete blink rate will cause dry eyes. So due to evaporation, easy evaporation, and then the meibomian gland disease. So these functional causes are modifiable factors compared to organic causes like Sjogren's or non-Sjogren's, like rheumatoid arthritis or lacrimal gland disease, etc. So how to examine a patient if complaints of a dry eye or some irritation? They usually tell there is a watering in the eyes. That is because of the mucin that is present. Usually mucin is the last to get depleted because of this globular cell. So that will cause discharge in them because there is no aqueous tears, no lipid layer, only mucin will be there. So how to examine these type of patients? So this is the normal tear film. So this is how you have to stain the ocular surface with the fluorescent. That is more important because this fluorescent staining will give you more details. Let me explain it in the following slide. This is the correct tear film height and how the ocular surface is stained uniformly. And Shimmer's test, you all know about this. This is how the tear film breakup time is measured. So ask the stain with the fluorescent. Ask the patient to just open. So look for the tear film breakup time. These are the areas of tear film breakup time. So this is a normal surface. Like if you see just like that without staining, you feel that everything is normal. Tear film is normal. But look at this. So the same eye, when it is stained, you get so many areas of staining. This shows dry eyes. So these are the various patterns of staining. So whenever ST is a very common test that you can do in your vision centers. If the ST is more than 15 mm, but the patient is complaining of dry eyes, that is, it is normal. ST is normal, but patient is complaining of dry eyes. Then ask for the age. If the patient is in menopausal age, then mostly it is a it is related to the hormonal imbalance. So patient can be treated in the vision centers, or occupational hazards or exposure to the AC or fan or to the electronic gadgets. Ask them to do lifestyle modifications. So if the Shimmer's test is less than 15 mm, patient has no dry eyes, no treatment is required. Just ask them to review. And if the Shimmer's test is less than 10 mm, that is, it comes under moderate to severe. So refer the patients to base hospital. They need other modes of treatment like punctal cautery and anti-inflammatories, etc. So patient gives history of dry mouth and also dry skin. So this is a severe case of dry eye, which has to be referred very much immediately. Conjunctivitis, the big headache for us. Now the epidemic it's already in the middle. So we see so many patients, and so why patients are developing SPKs and few patients they don't develop SPKs. That all depends upon the immune response of the host. Nothing to do with our treatment. So whenever you see conjunctivitis, a pseudomembrane, so just clean the give a drop, put a drop of betadine, wash. So whenever patients coming to you, put a drop of betadine and wash thoroughly. Stay for 20 seconds and then wash thoroughly. That betadine contact time is also very much necessary. This itself has an antiviral properties, so it will wash away all the viral load. So if the patient gets an SPK, please don't panic. Tell them it is a treatable condition and refer to the base hospital. So don't allow it to become like this, that subepithelial opacities. So frequently you can ask the patient to come, but if the patient started developing a punctal epithelial erosions, so when that starts, then you have to be careful. The next step would be the SPK formation and then subepithelial keratitis. So if the patients end up like this, they need a very chronic treatment and follow up with us. Allergic conjunctivitis, there are so many forms of allergic conjunctivitis. You have to know whether it is seasonal or it is perennial or it is a vernal conjunctivitis or associated with some skin disorders. These are different manifestations of vernal keratoconjunctivitis. We do see all these type of patients in our clinics. And if you like if you give chronic topical steroid drops, they would develop a steroid-induced cataract, glaucoma, keratoconus, and scars. More or less, they would develop. So they would develop corneal ulcers also. That also is there. So if the patient is, I have a patient who had come to us like following some injury or something. So he was already using some for allergic. He was using some loteprednol drops. He had applied that for 2-3 days because he had he had experienced a similar type of symptom associated with the allergy, like that it's stinging pain and all those symptoms. So the patient had used the loteprednol itself and continued, and he had developed allergy. Sorry, the ulcer. So that would be the complications. So to avoid all this, please refer patients with giant papillae and the conditions which I showed like this. So these patients require surgical therapy more to avoid all this corneal lesions, complications. So management, as I said, it is if viral conjunctivitis, early presentation, give anti-inflammatory first. If the other eye is involved within 3 to 5 days, start topical steroids. So if one eye is only involved for more than 10 days, you can, and if SPKs are there, refer to the base hospital. Bacterial conjunctivitis can be treated at the base hospital. So all children and infants with the conjunctivitis have to be referred. Pterygium is another common condition. Whatever may be the classification, the grading of the pterygium, please refer the patients if of the pterygium if it is encroaching the cornea. So because it may cause so many issues with the it may cause problems with cataract surgery later. Hence, please refer these patients. More or less, this is another complication which we had. The patient had a bilimbal pterygium, and because of this focal elevation on both sides, patient had a tear film instability. The surfacing of the tear film over the ocular surface was unstable. Hence, he had some epithelial erosions here, which turned out to be ulcer later. So refer all patients except atrophic, non-progressive, asymptomatic patients. This is a very common condition. So this, I had put this slide because if you pull out the lower lid only, you can find out this lesion. And this is in the superior bulbar conjunctiva. So if you evert the lid, only you can find out all these conditions. So this is a case of rhinosporidiasis. Corneal dystrophies, you are familiar with all the conditions. Keratoconus, I just wanted to tell you one point in this. Here, if you pick up scissor reflex at the earliest in the vision center, that is a success of every vision center, I will say. Because here, this condition is can be treated if identified at an early stage. If patient has a minimal cylinder or minimal myopic astigmatism, patient presented to us and we do a C3R in them, it definitely stops the progression in those patients and they get better visual acuity. So this is these are some ocular surface degenerations that occur, has to be referred to the centers because to the base hospital because they cause these patients require surgical treatment in this case and also in climatic droplet keratopathy. Some uncommon diseases like SJS, which I had mentioned before, this patient has come because of the drug allergy to paracetamol. And few patients, they come allergic to anti-epileptics also. So this is the OSSN, these pictures. Like they are, all these are benign OSSN lesions. So this is this occurs because of chronic eye rubbing. And the pingicula will turn like this. So this is called pseudoepitheliomatous hyperplasia. So this is a very common condition. We say nevus, whether we should refer these nevus to us or not, to the base hospital. So you refer the nevus to base hospital only when there is an increase in size. So nevus, when to diagnose? If there are cystic spaces in the pigmentation. So then you confirm that it is nevus. So if there is an increase in the size, increase in pigmentation, increase in the vascularity, then you can refer. These patients are called, they are referred to as racial melanosis because it is associated with the dark skin individuals. And this is a patient which you have to refer immediately to the base hospital because there is a sudden appearance of a pigmentation. So if there is a sudden appearance of the pigmentation without any previous history, then these type of patients have to be referred because this would turn into a melanoma. So this is nevus of Ota. So everyone knows about this because it is associated with glaucoma and uveal melanomas, malignant melanoma. So this is lymphangiomas. So this can be treated with anti-inflammatory agents in the vision centers. This is a case of lymphomas. This is like this looks like a subconjunctival hemorrhage. But this patient would, if you ask the history, the patient would give it is there for a few months or so. This patient is a HIV patient who has got this Kaposi sarcoma. So this looks exactly like some ecchymosis or some hemorrhage. These are small cystic lesions, lymphangiectasias. These can be treated with local anti-inflammatory agents. So dermoids, so limbal dermoids. So if the patients are having a chronic irritation, they may be referred to base hospital for excision. This is a corneal dermoid. So this patient is a 5-month-old baby who has come to us with a corneal dermoid. So we have operated and we have done a deep anterior lamellar keratoplasty in the patient, and the patient is doing fine. So what are the take-home points? So who are the patients who can be managed in the vision centers? Superficial foreign bodies and not deep foreign bodies. So meibomian gland disease, mild dry eyes in old age groups, milder form of blepharitis, milder allergic conjunctivitis, dot infiltrates in the cornea if the telemedicine and follow-up is possible, and anterior acute catarrhal conjunctivitis. Cases that are to be referred are injuries, moderate to severe dry eyes, severe recurrent blepharitis, severe form of allergies, corneal ulcers, viral keratitis, and conjunctivitis involving one eye. Because mostly they have a herpes simplex. They are due to herpes simplex, so they need a chronic follow-up with us. Thank you.